This will serve as the remainder of the urinary lecture. If you refer to your newly uploaded revised syllabus, so this will cover the rest of the highlighted items that have not been covered. Interstitial cystitis, which is painful bladder syndrome, is chronic and it's painful and it's inflammatory. So it is not caused by bacteria or an infection. So interstitial cystitis causes painful inflammatory disease of the bladder. There's urgency, frequency. It's just like, it feels like a UTI, but it's not. It's more intense. There's bladder and pelvic pain. We don't know what causes it. It's possibly neurogenic, possibly hypersensitivity. The mast cells might change in the muscle layer, and it could be infection from an unusual organism, so not like your normal E. coli. Like I said, it's pain and bothersome, severe. They void more than 60 times a day and night. They just up and down to the bathroom constantly. Usually suprapubic pain. And please make sure you know where the suprapubic area is and how you assess for bladder fullness, where you would palpate for bladder fullness. And that's the suprapubic area right above the mons pubic bone. It could involve the perineal areas as well. As the bladder fills, there's more pain. These are things that increase the pain: postponed urination, like holding their urine, physical exertion, any pressure in the suprapubic area, decreased pain with voiding, but it's temporary. So when they empty their bladder, they feel better. So it's sometimes misdiagnosed as chronic or recurring UTI because it has those same symptoms. Treatments, nutritional and drug therapies. We want to reduce the intake of bladder irritants. Make sure you know what bladder irritants are. Smoking, caffeine, those things would definitely cause irritation. Calcium glycerol phosphate does reduce the irritation. Stress management, tricyclic antidepressants. Now you're going to see tricyclic antidepressants come up in several different areas, and the one that you need to know, which you're probably going to see, is amitriptyline. Also, we use analgesics, and they're usually urinary analgesics, like pyridium, which you have to know changes the color of the urine and also will stain the clothing. And Uracet's another one which changes the color of the urine to green. So that's things you need to tell your patients. Antihistamines, also physical therapy, and bladder hypodistension are treatment. So there's pain assessment. We have to do that. Dietary and lifestyle factors that increase or decrease pain. So with these patients, you really need a very good history and physical. We do a bladder avoiding log for 3 days and record the pain when it's most painful, where they're rating it. We're going to monitor for UTI with diagnostic studies, and here you should write to the side what diagnostic study would you do for UTI. We can discuss that in class, but you know what you would need to anticipate. Going to monitor their nutrition, avoid restrictive clothing. Remember, pressure on the suprapubic area adds to the pain. Coping strategies and reassurance, and then there's a resource, which is a website for assistance and support. Okay, we just did that, so these slides were supposed to be here. Okay. So here we talk about obstructive uropathies, and this is a really good picture of the kidneys and bladder, the ureters, all the parts of the urinary system, and it shows you different problems in here. So take a look at this, especially you people who are visual like me. It tells you what areas these are and what kind of things can happen here. Strictures, there's a stricture, there's a calculi that's actually in the ureter. Wait a minute, let me see if I can get my cursor over here, sorry. There's a calculi in the ureter right there. Shows you for ureteral stricture, narrowing of the ureterovesicular junction right there. There's a calculus in the bladder or tumors. There's the prostate, and hyperplasia. As it gets bigger, it obstructs the urethra. So take a good look at that and pay a little attention to it, because those are some very good visuals. Obstructed, we can cause things that cause obstructions, bladder, neck, or prostate, bladder outlet, be pressure there. Here's hydronephrosis, and hydronephrosis is excessive edema and fluid in the kidney, so the kidney swells up. It can be partial obstruction of a ureter or ureteropelvic junction, just like I just showed you. Both kidneys are only one functioning kidney involved. Changes in the renal function occur and the BUN increase. Hereditary kidney disease, going to talk about. Nephrosclerosis is those small arteries and arterioles cause reduced blood flow, and then the kidney tissue actually dies. Benign is age-related. They're usually older than 60, and these changes are due to hypertension and atherosclerosis. Remember that atherosclerosis, which is a buildup of cholesterol and plaque, if it happens in the heart, it's happening all over the body. Okay, so if that lipid panel or that is high, you know, all those things are high, we've got plaque buildup everywhere in the vessels of the main organs. It's everywhere. It just doesn't happen in one place. Polycystic kidney disease is one of the most common life-threatening genetic diseases in the world. Over 600,000 people in the U.S. are affected, and it's the fourth leading cause of end-stage renal disease. There is a genetic link. There are two hereditary forms. In the adult, it's autosomal dominant, which is 90% of the cases, and in children, it's autosomal recessive. So Punnett squares affects both kidneys in men and women. Cortex and medulla filled with cysts that destroy the surrounding tissue just by compression. So you've got cysts that are filled with fluid, could have blood or pus in them, and they're all throughout the kidneys. So those glomeruli are blocked. Your calyxes are blocked. So you really can't get good renal function. Initially, you see hypertension, hematuria, pain, or a heavy feeling in the back, side, or abdomen. And these kidneys get huge. I've seen one person with polycystic kidney disease bilaterally. It was an African-American male, and he looked like he had these two big lobs on the side. If he laid flat supine, you could see his kidneys, the outline of his kidneys. They were so big and so filled with cysts. And it causes chronic severe. There's a really good picture, all those cysts. So you can palpate them. At the end stage, you can actually see them. It affects the other structures because everything is getting large and compressing on the other vital organs. When the kidneys don't function, it affects the heart, the liver, the blood vessels, intestines, and the brain. The diagnostic studies are ultrasound or CT, and you also consider clinical findings and family history. There is no cure. You want to try to prevent or treat a UTI. A nephrectomy sometimes is performed, so the kidneys are removed. The kidney is removed, and then dialysis and a kidney transplant are methods of treatment. Look at the bladder. Urinary incontinence, that's involuntary leakage of urine. I know you've should have seen some incontinent patients by now. Most prevalent with older adults. Women are more than men, but not a natural consequence of aging. So everybody who's older is not necessarily incontinent. Men, it's common with BPH or benign prostatic hypertrophy or prostate cancer. You have overflow incontinence from urinary retention. with women is stress and urge incontinence. If you talk to older ladies in your family, sometimes they'll say if they sneeze, they might be a little incontinent or laugh. Or it could be urge incontinence. They've got to go and it's hard to hold their urine. So what happens is the bladder pressure is greater than the urethral closure pressure, and that urine leaks over. So if you remember drip, delirium, dehydration, depression, restricted mobility, rectal impaction, infection, inflammation, impaction, polyuria, polypharmacy. That's a good way to remember the causes of incontinence. So there are different types of incontinence. Stress incontinence is combined with urge, and that's a mixed incontinence. Like I said, stress incontinence is where they're either laughing or sneezing or putting stress on the bladder. And then that urge, when it's time to go, those things mix sometimes. Overflow, reflex, it can be a reflex. There's sometimes incontinence after trauma or surgery. Sometimes after having a indwelling catheter inserted, patients may be a little incontinence before they get their bladder tone back. Functional incontinence can have more than one type, and they can have more than one type. Functional incontinence is people who don't have easy, ready access to the bathroom, and I know you guys probably may not be familiar with that at all, but there are people who don't have ready access to a bathroom, and or they can't get their clothes off in time, and that's functional incontinence. So we get them to do a voiding record or a log 1 to 7 days and look at any provoking factors or anything that's associated. Of course, do a physical exam. Our diagnostic studies are our urinalysis. Post-void residual means that we allow them to void and then we do a straight catheterization to see how much urine is still in the bladder. Okay. Urodynamic studies and ultrasound. Many can be cured or improved. We really have to teach. There's a lot of education needed here. Treat transient reversible factors first, like if they've had a UTI, we want to make sure that gets resolved. If they've had a Foley catheter, we're going to teach them bladder exercises, Kegel maneuvers in women. And the interventions depend on the type of incontinence. It's individualized to patients. We look at lifestyle modifications. If it's someone who has functional incontinence and maybe has had a CVA or is having problems with buttons and things like that, you want to dress them appropriately where they can have easy access to get their pants down or whatever. Schedule voiding regimens. We ask them to set up a routine where they use the bathroom routinely at certain periods of time. Pelvic floor muscle rehabilitation. Those are your Kegel exercises, and we teach them. We teach ladies now if they're driving, when they get every time they get to a stoplight, squeeze their buttocks together and tighten that pelvic floor. Anti-incontinence devices and containment devices. Drug therapy and surgical therapy depends on the type of urinary incontinence. Urinary structural support, repositioning them, increased resistance of internal sphincter and intra-abdominal pressure receptors. The surgical therapy, there are several things: retropubic colposuspension and pubovaginal sling. A lot of times, if ladies have abdominal hysterectomies, they'll have this sling procedure, these sling procedures to tighten that bladder because they've had those kind of problems. Bulk agent injections and artificial sphincter surgery, which the sphincter surgery is complicated and can have complications afterwards. Want to identify their physical and emotional concerns because of dignity and privacy and self-worth. I forget you guys don't watch commercials, but there are lots of companies now who provide incontinence supplies. There is the For at nighttime, there is, for ladies, it's called the, I can't think of the name of it, but it's a wick type appliance that goes between the legs, right, in above the urinary meatus. It's like a pad that you place, and it's hooked to suction for at night so that people don't wet, ladies don't wet the bed. It periwick, that's what it's called. It's used in the hospital as well, and it really helps to reduce UTIs. Keeping somebody dry. Really think about the skin. And you want to plan to reduce or resolve those factors. So there's tables 4517 and 4518 that points out treatments. So the retention is the inability to empty the bladder with voiding or the accumulation of urine because of the inability to void. This is where you're going to see bladder distension. And this is where you will palpate the suprapubic area. For instance, post-operatively, we expect patients to void within the first 8 hours. If not, we become concerned about urinary retention. We can now do a bladder scan. And then we do all those non-invasive things to promote voiding, like turning on the water, putting their hands in warm water, standing them at the bedside if it's not contraindicated, sitting them on the bedpan, doing all those things, pouring warm water over the urinary meatus, trying to get them to void regularly, and then giving them time. Also, you want to think about this is very important when it comes to your intake and output, because if they've got IV fluids going and they're drinking and eating, and maybe they just came back from surgery and they just cannot void, you'll have an order for catheterization, and usually it's an in and out catheterization for urinary retention over a certain amount of urine. That's the way the order will read. So if that bladder scan is positive and they have more than 200, I think it is, in the bladder, you'll have an order just to do a straight catheterization. We don't want to leave Foley's in, and we don't want to catheterize people because of catheter-associated urinary tract infections. Patients can be dribbling or leaking, and there are pads for that and things for that. Acute is the inability to pass urine. It's a medical emergency. Chronic, incomplete emptying despite urination, that's where you get that post-void residual. If it's more than 100, you're going to repeat or further evaluation for UTIs. So bladder outlet obstruction, the bladder can't empty due to blockage, very common in men with enlarged prostates. Deficient detrusor contraction muscle can't contract with enough force to empty the bladder. So neurologic disease involving the sacrum, 2, 3, and 4, diabetes, overdistension, these are all neurologic causes. Chronic alcohol use and anticholinergic drugs. Remember, your anticholinergic drugs, dry as a bone, red as a beet, mad as a hatter. So when they're dry from the anticholinergic, sometimes they can't void, and that's a side effect of that drug. Diagnostic studies the same as incontinence, and the care is very similar as well. The drug therapy is on tables. It won't let me go back, I'm sorry. There's a table in your book on drug therapies. So surgical therapy, there's a transurethral or open techniques. For your prostate enlargement, it's called a TURP, T-U-R-P, transurethral retrograde, T-U-R-P, pyelography. Transurethral retrograde prostatectomy. But it's not taking the prostate out, it's just shaving it down so that the urethra is no longer constricted. Usually there's an abdominal or transvaginal approach if it's for women. pelvic organ prolapse. Sometimes the bladder has prolapsed because the ligaments are no longer strong enough to hold it up, and that's when they have those sling procedures we just talked about. With the TURP or the TURP, the patient goes to surgery. It's a very bloody surgery. They come back to you with a 3-way catheter, which means they have a Foley catheter in. It's a very large catheter. And there are 3 ports. One is the port where you inflate the balloon. And in these catheters, often the balloon will hold 30 cc's of water. Then there's a port for an irrigation. So there's a 3,000 milliliter bag of saline that is the irrigant that you hang and you connect to that port. And you turn that irrigant up and it infuses into the bladder. And then the 3rd port is connected to the drainage bag, and that collects the urine. And it's a very large drainage bag. It's usually 3,000 milliliters. And the urine is very bloody. There's frank hematuria after that surgery. It's expected. But the goal is to not allow that urine to clot, that blood to clot. Because that blood can clot and clot off that catheter, and the patient cannot pass urine or the irrigant. If they start complaining of pain, especially suprapubic pain, and they have a 3-way Foley with that irrigant, you need to turn that irrigant down and get somebody and hand irrigate that catheter, because there's a clot up there, and it's a big clot. So you'll see a lot of hematuria and clots when there's a 3-way catheter after a TURP procedure. So for acute, we have to put a catheter in, and if it's acute urinary retention emergency, we have to consider leaving a Foley in for a little while. We want them to drink small amounts throughout the day, be warm when trying to avoid excess alcohol, unable to avoid drinking caffeinated coffee or tea to increase the urgency. For chronic, there are a lot of behavioral methods like toileting every 3 to 4 hours. Sometimes catheterization. There are some gentlemen, when they get older and they have BPH, even if they've had the TURP procedure, if they come into the hospital or they get immobile for a while, they have problems urinating. And if they need catheterization, oftentimes it has to be done with the urologist will come in and do it with a special catheter that we'll talk about in a little while. Sometimes they have to have surgery and have a urinary diversion, or they may have to have a suprapubic catheter inserted directly into the bladder through the skin in the suprapubic area, specifically if it's neurologic that's causing the urinary retention. You've learned how to insert a Foley or indwelling catheter, and they're done for relief of retention. Bladder decompression during surgery. A lot of times now when patients go to surgery, the Foley is inserted after they're asleep and is taken out right as they're awakened. So unless it's a urinary surgery or a GYN surgery, a lot of times the catheter comes right out. It's very important to do accurate intake and output. If there's a stage 3 or 4 pressure ulcer and it's not going to heal and the patient's incontinent, sometimes a catheter is inserted. And if there's a terminal illness and the patient can't void, it may be done. For intermittent or in and out catheterization, or you'll hear the term straight cath, relief of retention, in order to do a diagnostic study or testing, or we need a sterile specimen. Patients incontinent and we need a sterile specimen, then we may do a straight cath, because we know we're doing a sterile procedure, and then we are able to obtain a sterile specimen. Sometimes medication is instilled into the bladder, has to be done through a catheter, and to measure the resistance. Unacceptable reasons for routine urine specimens or convenience of the nurse or the patient's family, because there are catheter-associated UTIs. And those are complications. Most common healthcare-acquired infection there is. Other complications of bladder spasms. If a patient has a catheter and they have a bladder spasm, urine will come around the catheter. They'll be wet. A lot of times, to help that, we will insert more water into the balloon and make sure that the balloon is pulled taut up against that bladder outlet, the urethra. Periurethral abscess, chronic pyelonephritis, urosepsis. These are all complications from having a long-term catheter. So this talks about the construction. It's important that you know what catheters are made out of. They're not made out of latex so much anymore as they are silicone because of people with latex allergies. The lumen size, 14 to 16, common in the woman. And most of these are French. You'll hear 14 or 15 or 16 French. In the men, 14 to 18 French. If a man has a TERP, you might see a size 20, 24. And that balloon capacity goes from 5 milliliters to 30. There are 4 routes. Urethral, which is through the urethra. Ureteral, which is into the ureter. Suprapubic is straight into the bladder through the suprapubic skin. And nephrostomy tube is straight into the kidney through the skin. So A is a simple urethral catheter. B is a mushroom tip catheter. And C is I don't know what that is. What does that say? I don't see a coude. I'll look at that to see what type of catheter C is. There it is. Okay. So this curved tip right here, E, is a coude catheter, and this is when a man has BPH, and the physician has to come and actually put it in. This curved tip, or especially trained nurse, this curved tip allows you to maneuver past that enlarged prostate and get the catheter in. And this is your 3-way Foley, okay? This is your port for your irrigant, your port for your drainage bag, and then your balloon to inflate your balloon. So these are the things that we do to prevent the catheter-associated UTI. Determine the need for it, choose the appropriate size and type, insert it in a patient with urethral trauma, pain, or obstruction. Develop that plan of care to decrease the risk of infection. And because this is a national patient safety goal, we assess the patient every day if they have an indwelling catheter. There's a certain criteria. If they meet it, that catheter can come out. Teach patient catheter care. Use a sterile closed drainage system. We do not open that drainage system or disconnect it for any reason except for irrigation in that 3-way Foley. Must use sterile technique if you need to open that system. Change is not necessary if it's in less than 2 weeks. Use a sampling port for urine culture. Prepare the puncture site with an antiseptic solution. So you don't disconnect it. If the patient has a Foley catheter and you need a specimen for a urine specimen for CNS, you don't disconnect it. You clamp that catheter, which is you put a kink in that tubing for 15 or 20 minutes, allow that urine to flow, and then you clean that sampling port, usually with hexachlorophene. You glove, you draw that urine out of that sampling port and put it into that sterile cup. And for board purposes, for NCLEX purposes, only a licensed nurse can do that because it's a sterile procedure. Although in the hospital, techs and aides do it all the time. We use a leg bag if there's a long-term catheter, and that leg bag is strapped to the patient's leg, and connect it to the catheter so that they can ambulate and go out and not have to drag the big bag. And we want to take it out as soon as possible. We want to make sure it's the RN's job to delegate the catheter care to the UAP, but we want to make sure it's unobstructed, has a downhill flow, that collection bag is emptied, that it's not dragging on the floor, that they get catheter care and perineal care once or twice a day. Do not use lotion or powder near that catheter. The ureteral catheters are placed through the ureter and is thread up the urethra and bladder with cystoscopy. Surgical insertion through the abdominal wall into the ureter. So post-op, any catheter or any tube that a patient has, your primary goal is, number one, that it remains unobstructed. So you're always assessing it for kinks. And number two, that they not get any infection, because that's a foreign object in the body. So it's used post-op to prevent obstruction. So we record that output separately. If there's a urethral catheter, it has a place for output. And then if there's a Foley, it has a place for output. If they're voiding, that's a place for output. Make sure there's no tension. Make sure you do not clamp it. Aseptic technique, if you have to irrigate it, you want to monitor that output. If it's in the ureter, there should be urine streaming constantly coming from the kidney. So remember that. The renal pelvis holds 3 to 5 milliliters, and increased volume can cause tissue damage if you have to irrigate. The suprapubic catheter is urinary diversion. It could be temporary or long term. Like I said, it's inserted through the abdominal wall, straight into the bladder. You want to make sure it's not kinked. You want to tape it to prevent dislodgement. And you want to make sure that skin is protected at the insertion site, and make sure it's patent at all times. The nephrostomy tube is inserted through the flank incision into the renal pelvis, going straight into the kidney to preserve renal function. You want to avoid kinking, compression, or clamping. You got to be very careful with this one. Check the patency. If the patient has excessive drainage or pain around the tube, need to notify the surgeon. Strict aseptic technique if irrigation is ordered. Straight into the kidney. Intermittent catheter or straight catheterization or in and out. You want to make sure that you prevent urinary retention and stasis. And you want to use that with neurogenic bladder outlet obstruction. And it's inserted every 3 to 5 hours for neurogenic bladder. And we teach patients to self-cath. And when we do, they can use their same catheter, clean it with soap and water, and let it dry, because they cannot infect themselves if they do clean procedure. It's a clean procedure when the patient is self-catheterizing. Variable techniques and protocols. You have coated and uncoated catheters. You have single use or clean, which is multiple use, inserted by the patient, caregiver, or HCP. Now your patient, if they're self-cathing, it's a clean procedure. If the caregiver is, it's a sterile procedure. Okay. Surgery of the urinary tract. There's several different surgeries. We talked a little bit about inserting tubes into the body. Those are surgical procedures. Indications for nephrectomy means you're going to remove one of the kidneys. Renal tumor, bleeding, polycystic kidneys, trauma. Open or laparoscopic. If it's open, that means we make an incision in the flank or the abdomen. If it's laparoscopic, just like a gallbladder surgery, we make 3 to 5 puncture sites in the abdomen. We want to make sure there's adequate fluids and normal electrolytes. They may have pain from positioning in the OR. The output measure and recorded every 1 to 2 hours. Now, this is the real formula for acceptable urinary output. And we teach you at least to be at least 30 milliliters an hour. But if you have a weight, or you have a patient who's in critical care, or a patient who's had urinary surgery, it needs to be 0.5 milliliters per kilogram per hour. Now, you need to know that, okay? We're going to check their dressings. We're going to note the color and consistency of the urine, and is the catheter patent. And they'll get daily weights because we want to know, is there, and I know it's important in these patients. Post-op, same thing. This is a nephrectomy. You're going to check their respiratory status because they've had analgesia. You want them turning, coughing, and deep breathing, using that incentive spirometer every hour. We're going to be looking for abdominal distension and monitor for a paralytic ileus. So we're going to be checking bowel sounds, IV fluids, then oral fluids once the bowel sounds return, and they'll progress to regular diet. If the urine flow is blocked from cancer, neurogenic bladder, congenital abnormalities, and we have to make a urinary diversion. So this is a surgical procedure that's done in order to, when they cannot normally void or have urine output. And this shows you some of the methods. A is the ileal conduit, where they go into the small intestine, take a piece of the ileum, and anastomose it to the sigmoid colon. And then they isolate that segment with the ureters implanted in the posterior segment of it. So the ureter is connected to the piece of the ileum, a piece of the intestine. So what do you think the characteristic of that urine is going to be? It's going to be cloudy, and it's going to be foul smelling because it's coming through a piece of the intestine, even though it's urine. And that's normal for this type of diversion. That's what we expect to see. This is a cutaneous urostomy on the abdomen, where the ureters are brought out through the abdomen. It comes straight out of the abdomen, just like a colostomy. This is a urostomy. Let's see. This one's bilateral. Nephrostomy tubes. These tubes go straight into the kidney and drain out to the outside. They're brought out to the outside. So if it comes out through the skin, they have to wear an appliance or a bag. And the most common is the ileal conduit. And it tells you what happens. There's no voluntary control and no valve, so urine just comes into that device. And this is a urinary stoma. Looks very much like a stoma. Intra-abdominal urinary reservoir that can be catheterized. It has an internal pouch. So it's constructed from the ileum. Again, surgically created. Patient can self-cath. For example, there's a cock pouch, K-O-C-K, that has to be catheterized. All these have to be catheterized. So this is a good picture of the cock pouch. There's the stoma, and here's the pouch. So the stoma is just the external opening. It's connected to a pouch where the implanted ureters were connected to a big piece of the intestine, and the actual little piece is brought out of the skin. Orthotropic bladder reconstruction, when the bladder has to be reconstructed. It is in the correct anatomical position, and the urine is discharged through the urethra, so it's normal. It has a normal configuration. It's surgically shaped from various segments of intestines, and a new bladder is made. Preoperatively, lots of education, psychosocial support. Patients are very anxious. And then the wound nurse consultant, pre-op and post-op. They work very closely with these patients anytime there's stoma. You want to prevent complications because this is a surgery, and then prevent stoma injury and maintain the urine output. Mucus in the urine is expected. This is a piece of intestine. Meticulous skin care. You want to avoid incrustations with dermatitis and yeast infections. Change the appliance. You want to make sure that that's done well. If it's a continent diversion, you're going to catheterize it, make sure that that education is done, and the patient and family can do a return administration. And that's incrustations around that stoma. That stoma should be red and be. Want to catheterize it for post-op urinary retention. Bladder control may take up to 6 months. Want to empty the bladder every 2 to 4 hours by relaxing the outlet sphincter and bearing down with abdominal muscles. They don't feel the need to void. So that's that the bladder reconstruction. Body image. Anytime anybody's having a stoma or a diversion, you need to allow them to talk about their feelings and concerns, maintain their dignity and privacy. Discharge teaching. They need to know what's a symptom, a sign of infection or obstruction, how to take care of their stoma, how to get their supplies, make sure they've got plenty of supplies, and that you protect that skin. This is a retracted urinary stoma with a pressure sore from the face plate of the appliance that was put on.